Good morning, everyone. Today I am presenting paper on selective suture knot exposure in keratoprosthesis has the double advantage. I have no financial disclosures. My topic is under following headings. In our institute, we started Boston type 1 keratoprosthesis in 2015. We are using AIOC Pro, which is manufactured by Aro Lab. We have done 46 cases, out of which 24 are done in conventional keratoprosthesis procedure. 22 are in this innovative technique. We are started the pulsed antifungal therapy to our patients because most of our patients from the agricultural background to prevent fungal infection. And also we are avoiding the BAK-free antibiotics and changing the antibiotics frequently to avoid the resistance. On monthly follow-up, we have proper contact lens hygiene and we check the micro leaks very meticulously. Clean the cul-de-sac with betadine solution on the follow-up visits, and most of the cases end up with glaucoma drainage devices in 2 to 3 years down the line. We know the complications associated with keratoprosthesis. Glaucoma is the most common. Retroprosthetic membrane we can manage easily. Complication related to the ocular surface, wound leaks at the stem graft junction or graft host junction, infections and extrusions, posterior segment complications. Our little modifications in the surgical procedure will deal with the red part of this complication. Importance of BCL and ocular surface protection. Standoff care, it prevents the evaporative damage to the corneal surface and also protection of the fragile ocular surface from the mechanical stress, desiccation, stromal thinning, and corneal melting. Concept behind this innovative technique is, in penetrating keratoplasty, suture materials can incite some tissue reaction. Knots do so to a greater extent. Because of the exposed suture knots also stimulate local corneal neovascularization and inflammation. This is the vascularization which is disadvantage in penetrating keratoplasty was used to our advantage as innovative technique in keratoprosthesis for early vascularization and graft fusion. Exposed suture knots also cause foreign body sensation and irritation. This prompts the patient to seek immediate care when the bandage contact lens is fell off. This is how we intentionally exposed the 4 suture knots diagonally. The exposed suture knots attracts the vascularization, which will help in graft host junction fusion early. In which we have done 22 cases over the past 2.5 years with this technique. Out of 22 cases, neovascularization sets early, almost half of the time period compared to the previous cases. Still, further one exclusion of keratoprosthesis because of fungal infection. In previous cases, 2 exclusions, one because of sterile melt and one because of fungal infection. The most important thing is, almost half of the patients came back for the follow-up when the BCLs fell off because of the exposed suture knot irritation that they had. To conclude, the main advantages of the selective suture knot exposure in keratoprosthesis are the early vascularization leading to better fusion and leads to lesser chances of capro extrusion. When the BCLs fell off, patient seeks the immediate care, which leads to decreasing the ocular surface related complications.